There's a 14-year-old young person on your ward tonight who isn't there for anything medical. They've taken an overdose. They're medically fit and are waiting for a mental health bed that doesn't exist at present. This young person is being cared for on a children's ward, watched by a nurse who's trained to manage bronchiolitis and broken arms, in a bay full of curtain rails and oxygen tubing and 100 quiet ways to come to harm. If you work in acute paediatrics, you know this young person because they're on your wards most nights. Last fortnight, we spent the episode discussing fluids. This fortnight, I want to start somewhere we talk about far less and meet far more often. The young person in crisis who's parked in our care and what we can actually do to keep them safe. To do this, we're going deep on a new UK consensus study on mental health risk on the wards. Then we'll look at forearm fractures and what happens after the cast goes on. And in What's Caught My Eye, highly toxic ingestions in toddlers, whether early introduction of egg really cuts egg allergy, and from our good friends at Peruki, a refresh on the UK and Ireland research priorities for paediatric emergency medicine. I'm Ian Lewins, and welcome to Two Peds in a Pod. Welcome to Two Peds in a Pod, the paediatric medical education podcast about thinking clearly when it comes to child health. Each week, we take a paper, a clinical dilemma, or a tricky topic and work through what it actually means for your practice. So, whether you're in emergency care, general paediatrics, or you see children as part of a wider healthcare role, this is a place to step back, challenge assumptions, and sharpen your thinking. Welcome to the show. Okay, let's start on the ward. Every acute paediatric unit in the country has become, by default, a holding environment for children in mental health crisis. These young people come in after an overdose or an act of self-harm. They're medically cleared, and then they stay, sometimes for days, sometimes far longer, because the specialist bed or the community team they need just isn't available. We admit them to keep them safe, and the uncomfortable truth is that a general children's ward isn't designed to be a safe place for a young person who wants to hurt themselves, and most of the staff caring for them have had little or no mental health training. So the question that the first study we're looking at this fortnight asks is a very practical one. While these children are with us, on our wards, in our care, what can a general paediatric team actually do to reduce the risk? Not what should the system look like in 5 years, what can the nurse and the registrar do on a Tuesday night? This is a UK study published in the Archives of Disease in Childhood, led by Kaltzer and colleagues. It's a mixed methods piece of work in 2 stages. First, the team built a list of risk mitigation strategies. They did a systematic review, they ran qualitative interviews, and they pulled it together through thematic analysis. Then, they took that list to a panel of 16 people, healthcare professionals and experts by experience, and prioritised the strategies through a structured consensus process. The clever part is that they mapped each strategy against clinical risk level, low, medium, high, very high, using a validated paediatric mental health risk assessment framework. They started with 26 candidate strategies. 16 of them reached consensus, 70% agreement or more, for being clinically useful. And the strategies that made the cut are strikingly ordinary in the best possible sense. Structured safety checks on admission and then repeated every day, not just once at the front door. Proactive changes to the environment to take the triggers out of the room, noise, crowding, and the ligature risks we walk past every day without seeing. Active one-to-one observation, but reframed. The point of the special is therapeutic engagement, being with the young person, not sitting in the corner doing surveillance, timely assessment and quick escalation to specialist mental health services, and routine multidisciplinary safety huddles, so the team is actually talking to each other about the child or young person. Here's what I like about this. It turns a feeling of helplessness into a list of things you can do. The instinct when one of these young people arrives is that this isn't our job and we're not equipped. And there is truth in that. But this study says the general team isn't powerless. You can do a structured safety check. You can take the ligature points out of the bay. You can brief the person doing the one-to-one that their job is to engage, not just to watch. And because the strategies are mapped to risk level, you can match what you do to how worried you are, rather than throwing everything at everyone. The honest caveat is that this is consensus, not outcome data. 16 experts agreeing that something is clinically useful isn't the same as a trial showing it reduces self-harm on the ward. So read it as a framework to structure good practice. It's also not a substitute for specialist assessment. Escalation to mental health services is itself one of the prioritised strategies, not an optional extra. But as a piece of work you can take to your own unit and turn into a checklist, it's genuinely useful, and it speaks to a problem that sadly is only getting bigger. Okay, from the ward back to the front door, and something we all do constantly, the forearm fracture. We see them all the time. We reduce a good number of them, we put on a cast, and we send the child home with an appointment and some advice. And then mostly we stop thinking about them. The next story is about the two ends of that encounter, getting the reduction right, and what happens after the child leaves with a cast on. This paper is in Paediatric Emergency Care for Romem and colleagues, a retrospective study from a single centre. They reviewed over 4,500 forearm fractures and looked in detail at 551 children treated with a full circumferential cast in 1 year. The outcome they cared about was the unplanned return to the emergency department within the first week. 12% came back within 7 days, which is 1 child in 8. And when you ask why, it's almost certainly pain. 92% of the returns, and almost all of them, around 95%, needed the cast adjusting in some way. But the average hides the important bit. The return rate depended enormously on the fracture. Distal, both bone fractures, radius and ulnar together at the wrist, brought children back nearly a quarter of the time. And it was higher after a manipulation than after casting a fracture in situ, 16% versus 4%, more than 3 times the odds. Put those two things together, a distal both bone fracture that you reduced, and the return rate peaked at 27%, more than 1 in 4. Now, the reassuring part, there wasn't a single compartment syndrome, and over 98% completed non-operative treatment successfully. So, these returns are overwhelming pain and cast problems, not disasters. There's a comparison piece in Archives from Leo and colleagues that sits at the other end of the encounter. It asks whether point-of-care ultrasound can guide the closed reduction itself. It's a short structured evidence review rather than a new trial, so I treat it as a prompt to think about ultrasound at the bedside rather than the finished answer. But it points at the obvious upstream lever. If you can see the reduction is good before the cast goes on, you may not be seeing that child again in 5 days. So, what do we do with this information? For us, it's about expectation setting and safety netting and being specific. If you've just reduced a distal both bone fracture, the evidence says that this child has a 1 in 4 chance of coming back in pain, needing the cast adjusted. That's not a failure, that's the natural history, so tell the family that. Tell them what pain to expect and when to worry. And make sure your safety net actually distinguishes the high-risk fracture patterns from the low-risk ones, rather than handing everyone the same leaflet. It's a fair question for your department too. Are we casting and following these up in a way that risk profile suggests we should? And could a better reduction, ultrasound assisted or not, cut that return rate at source? One honest limitation is that this is a single centre data from outside the UK, so the absolute numbers won't map exactly onto your department. But the pattern, that reduced risk fractures are the ones that bounce back, will be familiar to anyone who's run an ED or a fracture clinic here. Let's move on now to what's caught my eye this fortnight. 3 quicker ones. First, does one pill really kill? This is a prospective registry across 58 Spanish emergency departments in paediatric emergency care, looking specifically at accidental ingestions of so-called highly toxic drugs. The agents we're taught can kill a toddler in a single dose in children under 8. And of 61 ingestions of these highly toxic drugs, most often cardiovascular medicines and opioids, only 4 children, under 7%, were even symptomatic. None needed advanced airway or circulatory support, and there were no deaths. The reason this matters? The one tablet can kill list shapes how long we observe and how hard we worry, and this maybe is a gentle nudge towards more evidence-based risk stratification rather than blanket alarm. The caveat? It's a small number of genuinely toxic cases in a registry. So this argues for better stratification, not for dropping your guard with the agents that really do warrant it. Next, did earlier egg introduction actually cut egg allergy? This is from JAMA Paediatrics from Coplin and colleagues, a comparison of 2 population-based cohorts of 12-month-olds in Melbourne, one from before and one from after guidelines were changed to recommend earlier egg introduction, with egg allergy confirmed by skin prick test and oral food challenge. As the typical age for introducing egg fell from 8 months to 6, confirmed egg allergy dropped from 9.2% to 7.6% overall, and far more steeply in the infants at highest risk, those with early eczema, from 36% down to 21.9%. Why this matters? This is real-world population-level evidence that a weaning guideline change actually moved allergy prevalence, not just efficacy under trial conditions. The caveat here is that it's an Australian before and after comparison, not a randomised trial. So it shows association at a population level, but it lines up with the direction of UK advice on early allergen introduction. And finally, new research priorities for UK and Ireland paediatric emergency medicine. This is in the EMJ, the Emergency Medicine Journal, a James Lind Alliance priority setting partnership that rebuilt the research agenda for our speciality across the UK and Ireland, 10 years on from the original, and this time with patients and carers in the room, not just clinicians. From 655 submitted questions, the process distilled a new top 10 research priorities, agreed by consensus between families and health professionals. Why does this matter? Well, these 10 questions will steer what gets funded and studied in paediatric emergency medicine for the next decade, so they're well worth knowing. And this one comes from the Peruki network, which some of you will know from our other podcast. The caveat's a simple one here. A priority list is a map, not a destination. It tells us what we've agreed to try and answer, not what the answers are. If you want to hear more about this study, go to episode 81, when we spoke to main research lead Dr. Charlotte Sloan about the James Lind Alliance and priority setting in UK paediatric research. So, 3 things I'd take away from today. 1. When a child in mental health crisis is on your ward, you are not powerless. Structured daily safety checks, taking the risks out of the room, and one-to-one care aimed at engagement rather than surveillance are things that any general team can do, and now there's a consensus framework to organise them. 2. Most children come back after a forearm cast because of pain, not catastrophe, but if you've reduced a distal both bone fracture, 1 in 4 will come back, So safety net those families specifically rather than generally. And 3, the one pill can kill teaching deserves a more careful, evidence-based look, because most ingestions, even of highly toxic drugs, stayed well in this large Spanish registry. As always, all the references and DOIs are in the show notes. If this episode was useful, please share with a colleague, and I'll see you in a fortnight. Thanks for spending your time with us on Two Peds in a Pod. If this episode sharpened your thinking, make sure you're following or subscribed wherever you listen. Share it with your team, use it in your next teaching session, and let's keep the conversation going. If you value this kind of learning, please leave a rating or review. It genuinely helps more clinicians find the show. We'll see you next time.